So we were talking about inflammatory disease, a lot of rheumatoid arthritis. What do you think of this case, Jennifer?
So it does look like there's some increased fluid signal intensity in that fourth extensor tendon compartment, as well as possibly the second. So this may represent tenosynovitis. And all of that looks like might be synovial thickening within the tendon sheath, diffuse synovial thickening. And also in the flexor compartment, there's some synovial thickening. Okay, so we see diffuse synovial thickening in the flexor and extensor compartments, so probably some rheumatoid.
So this is rheumatoid arthritis. And it's not as bright. These are low-field scanners, but if it were more of acute disease, it would be brighter on the fluid-sensitive images. This is more chronic.
All right, so it's kind of marked synovial thickening. It doesn't look exactly like fluid involving that extensor tendon. I'm trying to. Is it going to be the ECU? And I'm just trying to look at the tendon itself, if there's longitudinal split tears within, or if it's just severely tendinotic. But it's just marked tenosynovitis of the ECU. But I think it's grossly intact. There might be some partial tearing, but yeah, it looks like a longitudinal split tear.
So there was a longitudinal tear and chronic severe tenosynovitis of the sixth extensor compartment in the patient with rheumatoid arthritis.
What would you do for that?
Treat the rheumatoid arthritis things first thing.
Yeah.
Okay, so so why are we interested in doing all this stuff? Well, we know that now that there's effective therapy, it really raises the bar for making an early diagnosis. And we know that you can get a lot of destructive disease, both to bones and to the tendons, fairly early on in rheumatoid arthritis. So making an early diagnosis and treating early is now the critical factor in properly treating rheumatoid arthritis. And we know that MRI accurately detects the erosive phenotype, which may push you into using TNF-alpha inhibitors much more aggressively than you otherwise would, even though they are very expensive. And we know that MRI is more sensitive to bone changes than X-ray. And we also know that you can get bone injury, can be progressive and asymptomatic in people who are in clinical remission. And therefore, being cognizant of the fact that the patients may be asymptomatic but may have progressive bone destructive disease is important to recognize. And we know that tight control leads to better outcomes.
The prior image that we looked at, John, the extensor carpial nares, I think it was.
Yeah.
The way you fix these is you excise the tissue from the inside of the tendon that is degenerated, and of course there's swelling around there and synovitis. And so after you excise that tissue, then you whip stitch it. In other words, a running stitch, and you thin the tendon down so that it can glide a lot smoother through that area. There are a lot of tricks that can be used in today's modern world.
Good, thank you. And then to just remember that you can have very aggressive bone injury in the first 2 years of the diagnosis. So back in 2010, the American College of Rheumatology and the European League Against Rheumatism came up with a joint new system for making the diagnosis, because the old ACR system, American College of Rheumatology system, was very insensitive. It only really picked up chronic irreversible disease. And we also know that a lot of studies that show that MR is very effective at detecting early bony disease. And we can pick up more erosive changes, synovitis, bone osteitis, much better than other techniques. And there's not been as much evidence for ultrasound, though you can certainly see erosions with ultrasound, but there are a lot of hidden areas and joints where you can't really see them reliably with ultrasound. So we really believe that MR is a more valuable technique for really staging disease, which may be important for early diagnosis, because there are a lot of hidden areas where you may miss things with an ultrasound. So it hasn't been quite as well studied. This is just some other stuff. So this is no longer considered to be correct, but there was a time when we really thought that all RA patients at the time of diagnosis should have an MRI to adequately stage the bone disease. Most rheumatologists, at least in the US, don't feel that that's important, though the Europeans are much more aggressive about use of MR than Americans are, though for as far as I know right now, all drug therapies that are being tested to get FDA approval, the FDA is now requiring MR to be used in the staging of those patients. Not clinical alone is not adequate in order to get FDA clearance. We believe that people with osteitis should really get maximum therapy to stop the disease before you get bone erosive changes that are irreversible. And at one time we repeated the MR until we had stable bone disease, and then kind of stopped doing MR except for rarely. If you have progressive erosive disease, then you need to think about changing therapy if you're on maximum therapy. And then at one time it was believed that once you started a TNF-alpha inhibitor, you had to stay on it forever at $20,000 a year. I think that was pushed a lot by the drug companies, but we found that in some limited studies, especially the studies by Quinn and all in arthritis and rheumatism, that wasn't really necessary for everyone. As long as you had a sensitive technique to determine when you have new osteitis, you could stop the TNF-alpha inhibitors as long as you could follow them with MR. And then if they started having bony osteitis again, then start them back on TNF-alpha inhibitor, and could possibly save a lot of money if you did that. The funny thing about it is that many people in rheumatology in the US complained that MR was too expensive, but typical MR reimbursement in Medicare patients right now is like $250 to $300, whereas the TNF-alpha inhibitors are about $20,000. So in reality, you could save a lot of money if you had more aggressive use of MR. But that's not considered clinically appropriate right now. And this was a study that was in JAMA recently, where they looked at patients where they used MR to treat them and adjust the therapy based upon the MR findings, and they actually did not find that MR was that helpful. There's a lot of criticism of this particular paper, but I think at least as these people used MR and trying to use it to treat patients, they found that MR was not as effective as we thought it was going to be in improving patient outcomes. Yeah, and then there's the question is, what is the role for MRI in psoriatic arthritis? And a lot of patients with psoriasis will come in with cutaneous lesions, and they may or may not have arthralgia or subclinical evaluation on MR in their joints, and then develop joint disease later. And it's what this group found is that if you take patients who have psoriatic arthritis and you do an MR scan of key joints, typically the people just do the dominant hand and wrist. If there are inflammatory changes on the MR, then the chance of them developing psoriatic arthritis is 60% versus only 13% if you don't have the MR findings. So they believe that it was important to screen patients with cutaneous psoriasis so that you could be much more aggressive at protecting their joints if they were to develop joint disease.
I think we've been talking about this now for over 20 years, John. And it's unfortunate that we still can't say that it's got an MRI because you need it. You have to give all kinds of excuses, like trauma and so on. It was just kind of sad.
Yeah.
What I've done in the past is I'd say the patient has a injury and get the MRI that way.
Okay.
It's worked out so far.
All right.
And I'm not in jail either.
That's good. That's good. Ashu, what do you think of this case?
All right, so I think there's some subluxation of the intermediate phalangeal joints. There's some erosive change, some periarticular erosions there. Also seen, at the distal fourth joint, and then along the, okay, and here you can see actually the erosive change of the fifth distal phalangeal joint with hypertrophic bone on bone, and almost looks like a cup on that distal phalanx proximally. Yeah. And then you can see some erosive changes for a second metacarpal as well.
So in the old days, if we'd see a joint like this on plain films, we'd call it erosive osteoarthritis. It's kind of a typical appearance, or we'll call it. And here we can see that we do have erosive changes in a number of different locations. But if you notice that this has a predominant of distal disease in both of these, even though you have some metacarpal phalangeal joint, and this is a kind of a characteristic appearance of psoriatic arthritis. And this kind of aggressive erosive changes with degenerative disease of the distal interphalangeal joints is kind of a characteristic finding that you can see in psoriatic arthritis. So that there are really two things to look for if the referring physician is concerned about psoriatic arthritis. One is primarily dominance of distal inflammatory disease, and the other is psoriatic arthritis as an odd disease where you get dactylitis, where you basically get inflammatory changes along one ray, where you can get tenosynovitis and synovitis within the joints and the tendons, just involving one ray. We'll show some examples of that, but that's a very characteristic finding in psoriatic arthritis that's rarely seen in any other diseases.
Okay, so here we can see marked erosive changes and bone-on-bone articulation of the DIP joints of the first and second digits, and there is some soft tissue swelling surrounding that second digit, so this may represent psoriatic arthritis.
You've seen a lot of degenerative disease in joints all over the body this year in the program. What you can see here, this looks like much more aggressive erosive changes than we typically see just with standard degenerative disease. And if it's in the interphalangeal joints of the hand, when you see that, you've got to be very concerned about psoriatic arthritis.
Okay, so I don't know if that's just how it's cut, but it looks like there's kind of narrowing of the distal aspects of the middle of the intermediate phalanges, kind of like tapering and erosive change, kind of involving. Sorry, the DIP. Well, the distal aspects of the middle phalanges at the DIP joints. Yeah, but it's almost like the middle one. Third digit. I was trying to figure out if there's like some sort of like pencil and cup type, almost deformity. I don't know if it's just cut through it. Okay. And then you can tell that the MCP joints are relatively spared. So you're looking for like a psoriatic arthritis type.
Psoriatic arthritis. Yeah. Issue.
All right, so we have a 68-year-old male with psoriatic arthritis. We're looking at the carpal bones here. We can see distinct erosions throughout the carpals and some marrow edema. It looks pretty extensive, and I think there's some synovitis as well within throughout this. And yeah, you can see the extensive synovitis both dorsally, and I think it's involving a lot of those extensor tendons as well.
Yeah.
So this looks like pretty bad psoriatic arthritis.
So this could be either psoriatic or rheumatoid or a combination of both. But this happens to be a patient who just had psoriatic arthritis. Yeah.
We have a 50-year-old male with long-standing psoriatic arthritis, and there's marked narrowing of both it looks like some of the PIP joints as well as some of the visualized DIP joints. I don't see the distal phalanges very well. I'm not sure if it's the slice or severe erosive changes. Okay, so there is some volar subluxation of the looks like middle phalanx with respect to the proximal phalanx dislocation.
So you can see this kind of instability at the metacarpophalangeal joints with rheumatoid arthritis, though usually it's not this severe, but we saw this kind of volar displacement of the distal bone with respect to the proximal bone at the metacarpophalangeal joints in rheumatoid arthritis. And I've rarely ever seen that in psoriatic arthritis. But what I have seen in psoriatic arthritis is that same phenomenon occurring at the proximal interphalangeal joints, and I've never seen that in a rheumatoid case. So again, it just shows more distal disease in psoriatic arthritis.
You just haven't lived long enough, John.
Yeah. Some people say I've lived too long.
Swollen middle finger with skin lesion. Okay, so there's diffuse soft tissue swelling edema involving that third digit, and it looks like there's increased signal within the distal aspect of the middle phalanx and as well as the proximal aspect of the distal phalanx around the DIP joint. So this is probably just dactylitis that you can see in with destructive changes of that DIP joint.
Yeah, joint is thickened and swollen compared to the other. I mean, the one digit is thickened and swollen compared to the others. And you can see marked soft tissue thickening here and some arthritic changes within the joints. So this is a typical sausage finger seen in psoriatic arthritis from dactylitis. Good. Issue.
76-year-old female with long history of elbow pain and dorsal wrist soft tissue mass. We're looking at the elbow here along the ulna. There's a skin marker. You can see a little bit of calcification within the soft tissues. Here, we're at the level of the hook of the hamate of the extensor tendons. I think this is the fourth compartment. There's a lot of tenosynovitis and synovitis, some increased signal throughout that extensor compartment, some increased signal there along the extensors and some synovitis, maybe even split tearing.
So what are you going on here?
You have the, hold on, this is like a scleroderma.
Good. Yeah, this
syndrome.
Crest syndrome, which is really a form of scleroderma, where you get these soft tissue calcifications, which we saw there, typically Raynaud's, esophageal dysmodalities, sclerodactyly, and then telangiectasias. And this was a Crest syndrome. And it's also called, in some circles, limited scleroderma. Good.
Does that skin look unusual? On that last one, John?
Well, you got a little bit of loss of the fat signal within the skin. So yes, it is abnormal. This skin looks like it's a little bit more fibrotic and less fatty than the normal subcutaneous tissues.
every case of scleroderma that I've seen, and we had a scleroderma clinic at Wayne State, and everybody had a problem with their skin. It was it felt like a rock in some cases.
Yeah, right. Well, it is if it's calcified.
Yes, very, very much so. Far advanced.
So this is a 75-year-old female with chronic hand pain, and there are erosive changes of the DIP and PIP joints, greatest in the second and third DIP joints. It looks like there may be a gullwing deformity of that fourth digit DIP joint. This, to me, has the appearance of erosive osteoarthritis.
Fusion of this
Oh,
particular. I don't really know what erosive osteoarthritis is. I think that's an old term that
I was going to ask the same question, John.
yeah that I don't really use anymore, though. It's a term that was used in the past with plain films, and I think now we try to use more specific terminology. But I agree with you. Now, if we see erosions, we make that determination really by an MR examination, because we can really see the tissues more, and then we try to put it into more the etiologies of whether it's how much of it is just degenerative changes versus an inflammatory condition such as scleroderma or psoriatic arthritis, so that there could be more specific treatment for it. Yeah. So in here we can see a fusion here, which goes along with this as well.
I guess this may. Right. I would think this would be more of chronic degenerative disease. I guess she may also have. Yeah, she's. Yes.
Usually don't get effusions, it's just degenerative disease. This is
Okay, 65-year-old female. So there's this kind of low intensity structure within the superficial soft tissues along that adjacent to that first digit flexor. I'm not sure if it's involving the flexor tendon sheath. It's not fluid, so I wonder if it's calcified. You can get like these various like tendon sheath type tumors, like giant cell tumors, but that wouldn't be low intensity signal on this, or glomus tumors would also be bright. So I'm wondering if there's I'm not sure if it could be what part of, like, is it just soft tissue calcifications along the.
this is the,
But what exactly?
that's a fibrous nodule in scleroderma. Okay, Ashu.
All right, so 48-year-old female, forearm swelling, hardness. Okay, bug bite 3 months ago, developed swelling, cellulitis impression, no response to antibiotic treatment. And you can see, I think on the FAT-SAT PD, you can see diffuse edema near the fascial planes throughout the entirety of the distal forearm, and you can see increased T1 signal as well. And there's also, I think, some muscular edema throughout.
This is post contrast.
Oh, this post contrast. Okay, that makes more sense. So it's enhancing. Okay, so we're worried about necrotizing fasciitis here then, or a deep soft tissue infection, maybe even myositis. ESR is elevated, and so is the CRP. Not too bad though, not too elevated. Okay. So it is cellulitis with fasciitis. Okay.
That was the clinical diagnosis. This is 20 days later on antibiotics, and you still see it's around, but that's what it was thought to be. But
Did they save the forearm?
Huh?
I have no further follow-up after this.
Okay. Because
I get a biopsy, right? And
some of
see.
these wind up with amputations.
Yeah, I would be, I don't know the details of this, and I'm sorry I kind of put this in here. This could also be eosinophilic fasciitis if it's not responding to antibiotics, and could be an primary inflammatory disease rather than an infectious disease. But I don't think they got a biopsy, so I don't think we have a definitive answer.
So this is an 18-year-old with right arm pain for 2 months. Are these pre and post contrast images showing fascial enhancement of the muscles of the anterior compartment, and also some enhancement along the right thorax. And then here it looks like we have edema and fluid in the muscle compartments. He has increased white blood cell count with increased eosinophils, scleroderma on a punch biopsy. So this is another Crest syndrome? Eosinophilic.
Which is, it's an inflammatory reaction. And I think when you have a bug bite, it could actually be an inflammatory reaction to the bug bite, or you can have a unknown trigger for the inflammatory reaction where you get a lot of eosinophilics in. And so when you biopsy it, you just see a lot of eosinophils. And it's called eosinophilic fasciitis, but it's some form of a
Some form of allergy, isn't it, John?
Yeah, it's kind of like an allergy, but affects primarily the soft tissue planes.
Yeah, it's bad news.
Yeah, you can use MR to follow it as a marker for disease activity with thickening and increased edema and inflammatory changes in contrast.
Follow with the eosinophils.
Okay, so 49-year-old male with acute
So these are other examples of people who have acute eosinophilic fasciitis on their MR examinations. Yeah, what it looks like.
55-year-old female with mixed connective tissue disease. So we have the arrow just pointing saying this is a normal tuft. I'm not sure if the second digit, if that's just volume averaging out of the plane, or if that's actually okay. So then you have erosion of the tuft or distal aspect of the distal phalanx. Yeah, and then something involving multiple digits.
So what's this called?
Acrosteolysis.
Acrosteolysis on an MR examination. Shoot.
This is patient, 42-year-old female. We can again see at the third distal phalanx, also the fourth distal phalanx, the tuft. I think there's another acrosteolysis here, some distal tuft reabsorption. Okay, so you can also see some ulnar deviation. Okay, includes sclerosis along. Okay, this is a lupus case. Okay, yeah, makes sense.
So you can get a lot of abnormalities in lupus erythematosus. And, about 90% of these patients will have some sort of a musculoskeletal manifestation, myositis being one of the most common. But you can get acrosteolysis and tuft resorption as part of it. And typically it's bilaterally symmetric, and you can get a lot of changes with long bones. One of the things that we commonly see in lupus is bone infarcts.
Okay, so here I see some soft tissue swelling and edema within the subcutaneous tissue, and it looks like it's low signal intensity on T1 images, and there's some mild enhancement on the post-contrast images. I'm not sure if this is cellulitis.
Jennifer, it's a hand. Don't forget to tell us.
The hand, yes. Yeah, we have infiltration of the subcutaneous fat. I would ask if there's a prior trauma in this region or no trauma. I'm not sure.
Diffuse is a little bit more focal. This is sarcoidosis.
Oh, sarcoidosis. Okay.
Would you see lesions in the lung in this case, John?
You usually do, yes.
Yeah, I was wondering why there was no MR on the lung.
Yeah, or ask just for a chest X-ray to look for adenopathy.
Yeah.
So 52-year-old female. So we see some increased signal like edema, some swelling involving the medial gastroc. There is some low. I think there's some low signal intensity within it as well. Yeah, same thing I'd ask is like one if there was a history of injury, common. And if not, you'd be worried about some inflammatory myositis. There's some vascularity in these hypoechoic area, which is sarcoidosis.
So you get kind of a lace-like bone appearance on the plain films. Typical appearance of sarcoid bone disease with this lace-like bone with these big open areas where the trabecular bone has been destroyed.
Honeycomb.
Yeah, honeycombing, right. And here's an MR scan where you can see the honeycombing bone, x-rays with the honeycombing bone around it. And then here you can see these large soft tissue masses, which characteristically are associated with sarcoid disease. And here's the MR scan showing all this soft tissue disease with a little bit kind of like a honeycomb appearance in the soft tissues, and then the bone edema, which we see within the bone, and replacement of the fat. And so here's a kind of example of these cannonball type lesions within the bone that you can see with sarcoid disease. Another example, another example. And you can get sclerotic changes as well as lytic changes on plain films.
Doesn't it give a bit of an appearance of tuberculosis? Or I'm off.
You tend not to get the cold abscesses like you get well, by MR anyway. By plain films, it can look very similar to that. But you can't see all the inflammatory disease, which is different on TB than it is on sarcoid disease on the side. So by X-rays, yes. Yeah. Okay. And here we can see some tenosynovitis here around the wrist. A patient in this case with Lofgren's syndrome, which is tenosynovitis and seen in sarcoid. Okay.
Okay, so we have areas of. Okay.
Just another example of what sarcoid involvement of the muscles can look like. This is sarcoid myopathy. Here, why don't you take this case?
47 female dry and mouth for 17 years, right wrist swelling and pain. So we just kind of see call most of these kind of non-specific degenerative changes, the radiocarpal joint, kind of the mid-carpal articulations, as well as the second CMC. Then 4 months later, it's significantly progressed throughout. And given the history, and then the marked uptake on the bone scan, and given that history, you're thinking like Sjogren's syndrome. But also on the bone scan, when you have something that's multifocal like that, you can think of like complex regional pain syndrome. And then on MR, we're seeing there's just kind of diffuse, there's a lot of synovial thickening, especially involving those flexor tendons, flexor compartment. Yeah, and a lot of different areas of osteitis. So chronic osteomyelitis.
Okay, Ashu?
58-year-old male with hand wrist swelling, concern for tumor, carpal tunnel syndrome. Something wrong with that third distal digit, or is that on the first? No, I think it's just overlapping bone. Looking at the carpal bones, we can see a lot of soft tissue swelling along the volar aspect, and there's some degenerative changes of the lunate. Distally, a lot of soft tissue swelling there. Here we're looking, is there some erosive changes of the distal carpals there, and some meroedema, and okay, so here we can see on the axial sequences, we see a lot of synovial thickening throughout the carpal tunnel. It looks like it's there's some fluid as well. It almost follows the tendon sheaths pretty clearly on all three of the flexor tendons that we see there in that picture, and then there's some edema of the adductor there, opponent's pollicis maybe.
What are your thoughts here?
Well, it might be a connective tissue inflammatory disease. I would
Trying to look for characteristic erosions, but these aren't. But we see a lot of erosive disease here. So
I guess the soft tissue thickening. Okay, yeah. So with the soft tissue thickening, you can have gout. So that makes sense.
Yeah,
This could be gout.
54-year-old with fifth finger pain and swelling. There is irregularity and increased signal within that fifth digit flexor tendon. He may have tenosynovitis. Here again we can see irregularity and increased signal of the flexor tendon, and I don't see any erosions on this image. Oh, gout.
And 75-year-old male with chronic wrist pain. So I'm looking on the third radiograph. Is that just what angle we're to? Carpal tunnel view. So it looks like there's kind of some non-specific cystic changes in the proximal scaphoid, a lot involving the triquetrum. There's maybe a little bit of degenerative change at the radioscaphoid joint, and then there's kind of some little high density kind of amorphous, in the pre-styloid recess and around some, like
Those are calcific, aren't they?
Yeah, little calcific, amorphous little calcific densities kind of throughout the synovium. It wasn't really involving like along the joint, so it's not really chondrocalcinous. It's kind of more like synovial type. And there's some erosive change as well. I mean, it could still be gout.
You have to use calcium phosphate metabolic diseases as well, other things that can cause calcium phosphate deposition, but that was gout.
We have a 63-year-old male with pain. We have some dedicated images of I think this may be the first digit, I'm not sure, but there are some marginal erosions there along the PIP joint. And then with some overhanging edges. And then here we have some images of the radial collateral and ulnar collateral ligaments, and it looks like they're thickened. So I guess this may also represent gout. Yeah.
I think John has told us gout loves to be in areas where ligaments and tendons attach. And they just burrow in that area and get inflamed because they're needles-like, and they just continue to get worse.
So in the 65-year-old male with hand pain, so we see kind of marginal erosions involving multiple metacarpal heads with probably synovium extending into them. There's kind of synovial thickening surrounding. So I mean, you can see something like this in gout as well. But I guess it could be also be any sort of like inflammatory arthropathy.
Right, exactly.
I'll give you a little story, if I may, John. It's a mutual patient of ours.
Okay.
This patient had the gout, and the doctor had him on alpurinol, and then eventually took him off because his uric acid wasn't high enough. He has had a reverse replacement of one shoulder, the other shoulder, surgery on his hands. He has had bilateral hip replacements, and all because the doctor took him off alpurinol and never put him back on it and never tested him again.
Wow. Oh my gosh. That's sad. So this is what the urate crystals look like. They're like needles. What happens is that they get taken up by the macrophages, but they're too big, and they puncture the cell walls and extrude a lot of the internal biochemistry within the macrophages out into the surrounding soft tissues, which induces the inflammatory response. So this is really all a mechanically induced inflammatory problem, and it can lead to extensive destructive disease, as we can see here. Extensive gout. Okay. See who's next? Ashley, why don't you take this one?
It's just like being attacked by a porcupine.
Yeah, right.
You can see a large extraosseous soft tissue mass or soft tissue thickening with erosions of the adjacent proximal second phalanx distally. You can see the skin marker right there, maybe an overhanging edge there. I'd still be worried about some type of tophaceous gout.
There's the MR.
Much more clear on the MR. You can see that soft tissue kind of eroding into the distal aspect of that proximal phalanx. And it's enhancing, so consistent with gout.
Okay, so here we can see an osseous erosion within the radial proximal aspect of the lunate, and also maybe a smaller erosion there in the proximal scaphoid. And there is a large carpal joint effusion. I think these findings are nonspecific. They could reflect inflammatory arthropathy, synovial thickening. I guess it could also, I haven't seen this before, but I guess it could be gout.
What I found interesting, just on my own, is that gout can affect a whole bunch of different joints and also can affect just a single joint. I always found that kind of interesting.
Yeah.
Like my brother had gout and it affected his ankle only. That's the only joint. And then I've had other patients that affected just the great toe, etc.
So we have a soft tissue skin marker overlying this metacarpal head, and there's this kind of low intermediate density soft tissue right there, kind of in between the extensor tendon and the metacarpal head, with a small little erosion. And now we see this on the axial involving the second digit. It's kind of in between the tendon and along the bone. It might just be like focal synovial thickening with erosion, is similar to like the one maybe Ashu had, the tophaceous little gout.
Right. Ashu?
Sorry, is it me?
Yep.
Okay, so here we can see a large soft tissue focus eroding into the first proximal and distal phalanges. Again, don't see the cortical margins very well. This characteristically affects that distal phalangeal joint. This looks like gout as well. And there's yeah, you can see that it's a large soft tissue focus involving that, and there's some
Really destroyed
some
the
subluxation as well.
Yeah, it's really destroyed the interphalangeal joint, and this joint was very unstable.
Do we have to entertain the possibility of like other, like a mass or something, of like a destructive soft tissue mass?
Yeah, but I mean, a mass, neoplasm would be unlikely, but yes, you can have neoplasm there. So you have to have the full differential, right? Exactly. It could also be a chronic infection, such as coccidiomycosis and so forth.
Okay, so we have a couple axial images of the hand, and what I can see of the extensor and flexor tendons are intact. There's some kind of subcutaneous thickening there with a nodule. And here we can see an overlying soft tissue marker with that region of subcutaneous thickening. I guess this kind of looks like a prior sarcoidosis. It could be prior trauma or infection.
Also, the fingers flexed.
How about
contracture, fibromatosis, but this is kind of distal for that. So maybe a Dupuytren's contracture.
You can have Dupuytren's there.
Good. Yeah, this is a typical appearance of a Dupuytren's contraction.
Injections have gotten really good for the disease. So the first thing you would probably try would be to have it injected with that. I can't think of the name of the medication, but if you do a good job and just inject the scar, you can release it.
Good.
It's pretty neat stuff, except if you miss. You don't want to miss. The surgery is miserable. I never did a case. I let the hand surgeons handle it. Not that I couldn't do it, but I just don't want to.
60-year-old female with history of old fifth fracture, mass, and contracture. So we can see on the axial that the fifth digit is flexed, and then it looks like on the volar aspect of the third digit in the soft tissues, we see kind of this ill-defined, low intensity structure, which might be similar to the one we just had. This could be another Dupuytren's contractures kind of in that region. Yeah, because it almost looks like there's like a tendon there, but so these are going to be multiple Dupuytren's contractures, I believe. Yeah, so it looks like, there's not supposed to be any tendon tissue there, so.
53-year-old female with skin thickening, We have an ultrasound examination on the radiograph as well. You can see focal thickening at the metacarpal phalangeal joint. Oh no, that's the proximal, sorry, the proximal interphalangeal joint. And you can see that the ultrasound demonstrates kind of smooth hyperechoic focus there. It doesn't seem to go into the joint. I'd like to see an MR if there is one, but it looks pretty benign. Okay, so it's just an echo pad, so benign, sometimes symmetric.
That benign fibrous thickenings typically seen in older individuals, probably part of the degenerative process. Kind of in the same family as Dupuytren's, though. Okay.
Okay, so here we have an axial image through the hand, and there's infiltration of the subcutaneous fat along the ulnar aspect of the thumb, and there's also some subcutaneous nodule there along the dorsal first digit or second digit. It looks like there's just there's a homogeneous appearance. Is this post-contrast, some mild diffuse intrinsic enhancement? I'm not sure what the rest, yeah, I'm not sure. No, deep muscular upper neurotic fibromatosis. Okay.
Yeah.
Whatever that is.
Okay, so we have some on the PD sequence. We have a kind of intermediate density, ill-defined infiltrative soft tissue within the hypothenar region that has pretty avid enhancement on the post-contrast imaging. Again, somewhat kind of ill-defined. So could this be sort of like fibrous type scarring?
Yeah, so this is fibromatosis. To be honest with you, I would, just looking at this, I would be very concerned.
It could be T1, intrinsically T1 hypertension, because we don't have a.
Yeah, it could be, but this is awfully right. But yeah, I certainly would even be concerned about some malignant masses that could do this with infiltration. But this all turned out to be benign, and these are different fibrous type masses, and there's probably some inflammatory component to them with scarring. But I think that the overall pathophysiology of a lot of these fibrous masses is still a little bit unclear. Okay, Ashu.
You can see some increased uptake of the distal aspect of the first metacarpal as well as the distal aspect of the first proximal phalanx. On the MRI sequences, I'm not quite sure if I'm seeing anything abnormal here. Okay, so the fluid-sensitive sequence, there's increased signal along both the ulnar and radial aspects of that distal interphalangeal, the interphalangeal joint as well as the metacarpal phalangeal joint, and there's effusion extending both along the dorsal and volar aspects of that joint, and maybe some increased edema and maybe thickening. Actually, it looks almost mildly expansile of that distal first metacarpal.
And so this patient had pain in this region and had surgery more proximal.
Oh, they had surgery more proximally?
Yeah.
Could they have some early, early avascular necrosis or?
No. This was a patient, we used to call it reflex sympathetic dystrophy. It's typical of regional pain syndrome. It's thought to be a neurologic dysfunction, which is poorly understood, that can happen after surgery. I think this patient had elbow surgery.
Also called shoulder hand syndrome.
Oh, is that right?
Yeah, usually it affects the entire hand, not just the thumb.
Yeah, it can. It's very variable as to how it happens.
It's not that uncommon, actually. It's mainly seen in women, middle age.
So we have radiographs of the bilateral hands 3 months ago, and we can see subluxation and erosive changes of the left thumb IP joint. And yeah, there's some osseous destruction and erosion and some surrounding soft tissue swelling. This excisional biopsy, detritic synovitis.
That's what I showed. But what does this look like? If you just saw that, what?
This looks to me like it could be an inflammatory arthropathy, or it could be infectious. It's focal, and I don't see any other degenerative disease. I guess it could be post-traumatic osteoarthritis.
Looks to me like it's neuropathic. 2 months later, this is what they
Okay.
So this is actually a neuropathic joint.
Oh, I see. So then they have a cervical spine MRI.
So if it's the joint's all destructive, and it looks like it's been there for a long time, and the patient's not all that symptomatic, then always remember, if it's really a bad-looking joint, but you don't see a lot of you see a lot of destructive changes, but the margins are very sharp. Just always think of a Charcot type situation, and you can have in the upper extremities. It's usually from neck disease, and then obviously in the lower extremities, it's usually from diabetes.
Can you bring back that cervical spine X-ray, John? What level is that?
There's
2, 3, 4,
3, 4.
5.
This is
3, 4. That's not the thumb, is it? Should be 5, 6.
Yeah, but that might be down
here. It's interesting. It's just affecting one thumb.
Yeah, right. Okay.
No, we missed a couple, affecting pretty much the whole hand.
It's a 75-year-old female. So we have kind of multiple areas of destructive degenerative change, most prominently involving those, both bilateral first digit IP joints, that right there, the third and fourth PIP joints, kind of bilaterally. It's multiple deformities.
Base of the thumb.
Yeah, and this first CMC joint well, it's kind of mild.
This is another
the wrist.
Similar pathology.
Yeah, this also was a neuropathic disease.
That's kind of weird.
But it was on both sides.
Yeah.
No, all their styloids are gone.
Ashu.
All right, so we have a 41-year-old female with 3 days of acute pain and redness, rule out infection. You can see some calcification at that distal, at the proximal aspect of the distal phalanx, kind of along the volar aspect, palmar aspect. It almost looks like hydroxyapatite deposition when I'd seen the shoulder. You can see it surrounding the, kind of at the, adjacent to that flexor tendon. And you can see a low signal there on kind of all the sequences. I think both T1 and T2, and it's kind of actually a little bit on the radial, the ulnar side of the joint. I just based on the radiograph, I thought it was calcific tendonitis, but I don't. Oh, okay, so it is calcific periarthritis. Oh, it is calcific tendonitis of the thumb. Okay.
Yep, got it. Good.
So we have some CT coronal images of the wrist, and there's marked narrowing of the scaphotrapezial joint with cyst formation and osseous remodeling and erosions. Here again, we can see joint space narrowing with cystic changes and osseous erosion. Evaluate scaphotrapezial arthroplasty. Okay. So now it seems there are some post-surgical changes along the distal scaphoid and partial resection of the trapezium. I wonder if they did a tendon interposition, which we wouldn't see here, but
Okay, well, why don't we stop here, and we'll pick up on next week and go to a different topic.
Have a wonderful weekend, everybody.